Hi and welcome to part 2 of my penile rehabilitation in prostate cancer series. In part 1, I explained the rationale for penile rehabilitation, so if you don't understand why you should care about it, I recommend that you watch part 1 right away. In part 2, I'm giving you the information what to do before and after radical prostatectomy, and it all starts with PDE5 inhibitors. You know them by the name of Viagra or Cialis. My name is Stefan Buntrock, I'm a urologist and sexologist. Penile rehabilitation has been around for almost 2 decades. Many urologists advocate it after radical prostatectomy, but there are no guidelines on how to do it, and the body of scientific evidence is not very large, also including contradictory results, as always in research, because results are due to different study designs, methods, and patients included, so this is something that can be considered as normal in clinical medicine. I know it upsets many people because they think there should be clear messages, everything carved in stone, black or white. But that's life. The fact that there are no guidelines and lacking unequivocal results doesn't mean that penile rehabilitation doesn't work. It has to do with the fact that the overwhelming public interest in sex is not in the slightest mirrored within the medical community. Sexual medicine is put aside in medical considerations all too often, and frankly, many doctors don't really care about it. It is much more prestigious and rewarding to build a career around how to do surgery on a prostate than on how to rehabilitate the functional consequences. So it comes as no surprise that the number of clinical studies on this subject is rather small. Penile rehabilitation was the reason why I decided to expand my personal medical universe into sexual medicine. The essence of what I have learned and read is what I recommend to my patients when I counsel them before radical prostatectomy. Get nerve-sparing surgery if possible. In certain cases, it won't be possible regarding the risks for incomplete removal of the tumor, but very often it is certainly doable. Start pelvic floor training right away. Don't try to do it on your own. Get instructed by a physical therapist with experience in treating the pelvic floor. Start with PDE5 inhibitors immediately. In principle, it doesn't matter which one. I have a personal preference for long-acting substances, and the choice will be Tadalafil in the once-a-day dosage because it is available as generic pills, whereas Sildenafil still is very expensive. But as I said, short-acting substances will do as well. PDE5 inhibitors are also known by the name of Viagra, Levitra, Cialis, Standra. They are stopped for the operation but continued afterwards. Once again, why this is important is explained in the video I mentioned initially. Pause here and watch it right now if you are not following along. The desired results are nocturnal erections, even if they are only slight. I wouldn't expect daytime erections to happen. That would be asked too much, but if they appear, congratulations. If there are no whatsoever erections 6 to 8 weeks after the operation, I advocate injection therapy once or twice a week to get the penis to fill with blood and protect the cavernous bodies. In my experience, these erections might be a little painful to many in varying degrees. I have no scientific explanation for this, just a theory. Alternatively, a vacuum pump may be used without the constriction ring just to trigger erections and fill the cavernous bodies with blood. One has to keep in mind, though, that injections trigger an active inflow of arterial blood, whereas vacuum pumps cause a passive inflow of mixed venous and arterial blood. In my understanding of penile rehabilitation, more oxygenated arterial blood is more beneficial for the purpose intended. Shockwave therapy, ESWT, might be another option. If you are not familiar with shockwaves, please have a look at my playlist on this topic. At least in animal studies, shockwaves show to be effective in penile rehabilitation. And thinking about what they do and how they're supposed to work, it makes perfect sense to make use of ESWT within a penile rehabilitation program. Also when it comes to the dreaded perineal pain after surgery, because shockwaves are very effective in pain management in areas where inflammation is involved, and inflammation is one inevitable part in the wound healing process. I know that clinical studies are on the way to put this hypothesis to the test. Penile rehabilitation should be considered for 2 years because nerves regenerate slowly, and after this time, no further progress can be expected. This was a video about penile rehabilitation after radical prostatectomy. More is to come about radiation therapy, and sexual rehabilitation is a large field yet to be covered. Thanks for watching. Bye bye.